Once we have made the diagnosis, now we are moving towards the diseases which may affect the spinal cord and what may constitute the neuromuscular disorders. In this section, we'll be going through the motor neuron disease and poliomyelitis. We'll be going through what is spinal muscular dystrophy, what are the acute phase of poliomyelitis, what are signs symptoms of poliomyelitis, and how to deal with the polio. Although it's a very rare disease, motor neuron disease is actually, it could be an upper motor or lower motor neuron. It's the motor tract actually starts from the from the cerebral cortex in the motor area, and it descends down all the way towards the spinal cord. From there, the peripheral nerves originate and they invade the muscles. Probably, if there's anything wrong in the upper motor neuron region where this tract is cut off, it is called as pyramidal tract or corticospinal tract, or if the peripheral nerve gets injured, this whole results in a motor paralysis of the muscle, loosely termed as motor neuron disease. So, what are the signs symptoms? They include it can affect both the cortical motor neurons and anterior horn cells. Depending as corticospinal cord descends, it actually synapses on the anterior horn cells of the spinal cord. This way may present an upper motor neuron lesion leading to increased hypertonia, spasticity, or lower motor neuron lesion leading to hypertonia, hyperreflexia, and flaccidity. Usually it has four types. This may be if the centrally is defected. For example, there's something wrong with the cerebral cortex. This may be associated with dysarthria and difficulty in swallowing depending on which area is involved. There may be muscle cramps, atrophy, and fasciculation, or there may be associated frontotemporal dementia or emotional lability. Because as the motor cortex is adjacent to other areas which are also controlling other functions of the brain, if though all those areas are affected, this may result in frontotemporal dementia or emotional lability. So, what is motor neuron disease? It's actually one of the types of motor neuron disorders include spinal muscular dystrophy. These include basically the degeneration of anterior horn cells. This is classical presentation is lower motor neuron lesions. For example, these include two lesions, but usually the lower motor neuron lesion presents with hypotonia, hyperreflexia, and flaccidity. And this includes Burden-Hoffman disease, which is commonest form. It is autosomal recessive, diagnosed at birth, and soon afterwards usually associated as is hypotonia, hyperreflexia, and flaccidity. The baby is floppy, difficult feeding, and shallow breathing. Usually, it's highly lethal. The child usually dies within a year. Even if it does survive, usually it don't survive till adulthood. The other is Kugelberg-Wellington disease. This is a less severe form. It's inherited as autosomal dominant. It can also be inherited as autosomal recessive. Limb weakness, proximal muscle wasting, and paralytic scoliosis is usually associated, but it's also, as there is paralysis, this is associated with hypotonia and hyperreflexia, and it may be cause of delayed walking in children. If you see this diagram, this is the axon which is coming from the central nervous system. It's ascending all the way into this, in the muscles. When you see if this is cut from anywhere, this usually results in muscular atrophy. In spinal muscular dystrophy, what happens is the motor neurons which are arising from the anterior horn cells of the spinal cord, which is lying over, this results in the damage of this area, leading to muscular atrophy eventually of the affected muscles. Now coming to another disease, although it's nowadays is almost in some countries it has actually been cured. That due to vaccination of the polio, they've almost eradicated poliomyelitis. But in some countries, especially in third world countries, due to improper vaccination, they're still rampant and still can present in acute symptoms as well. And it is an acute infectious viral disease spread by oropharyngeal route that passes through the several distinct phases. Its clinical features include acute symptoms include acute illness, which may present as fever and headache in children. There may be paralysis, pain, and pyrexia. There may be residual paralysis that eventually developing into some kind of deformity, and there may be post-polio syndrome. Post-polio syndrome is usually that once acute stage is over, then people are actually the patients are cured of this disease completely, then suddenly there is a new onset of symptoms with this acute stage, although it's not a new infection, but this is kind of a reactivation of the latent poliomyelitis virus which is present in the body, leading to either the paralysis of new muscle groups or increased severity of symptoms in those muscle groups which were previously affected by the polio. The treatment, if it is an acute stage, sometimes although it can be really severe, and it can affect the respiratory muscles as well. And once it starts affecting the respiratory muscle, the patient may need a ventilatory support as well, because early treatment includes complete rest, passive stretching of the muscles, intermittent positive pressure ventilation as well. There may be a need of tracheostomy or tracheotomy, physiotherapy, and splintage depending upon what kind of muscles are affected. If the limb is affected, this may only require muscle stretching and splintage. But if the respiratory muscle is affected, this may result in severe respiratory compromise and may require a ventilatory support. Muscle charting is carried out in regular intervals to see whether how the disease is progressing in these children. Coming to the treatment, initial treatment is symptomatic, but late treatment depends upon what kind of a pathology has actually occurred. Treatment may, if the muscles are showing weakness without deformity, there's a different treatment, whether there's deformity is present or not, or whether the muscles are weak or are completely paralyzed, whether which group of muscle is affected, whether they're affecting the gait or not, that all determines what kind of option we are choosing for this patient. This may involve simple kind of a bracing, simple kind of splintage. This may require some kind of surgery in form of muscle transfers, or this may be the final option could be the orthodesis, because if the muscles around the joint are not good enough for transfer, then probably orthodesis, a bone-to-bone union or fusion, is probably the last resort, and it's a good resort because it helps them to ambulate very well for activities of daily living. Muscle weakness, if it's without deformity, usually causes only instability. There may be a loss of complex function, and if this is associated with passively correctable deformity, this may be due to unbalanced paralysis, will require suitable orthosis and muscle charting. And usually they can work in certain conditions with the way they do not have to use muscle against gravity. If it has come weakness or paralysis of muscle with a fixed deformity, then initial treatment may be splintage, or the last resort would be a tendon transfer. If tendon transfer is not possible, then probably may have to go for orthodesis or treating the paralytic scoliosis, for example. That is meaning going for the fusion of the bone so that they can carry out their activities of daily living. If it's a flail joint, that is the limb is flail enough and the muscles are too weak to move a joint, and they just this may eventually require balanced paralysis. If it's bilateral, then the patient will be on wheelchair bound, and probably nothing can be done. But if it's on the one side, then the patient will not be able to walk properly. Then we may have to go for some kind of splintage early on, muscle stretching, and then eventually orthodesis is the only option left. So continuing with the late treatment, then sometimes instead of presenting with deformity, they present with shortening. They have this shortening actually is problematic because with every walking gait, usually there's increased stress on the other. For example, if right leg is short, the patients usually would result in swaying of the pelvis on one side. There will be increased stress on the left pelvis, increased stress on the left knee and left ankle. So eventually the problem is that due to this kind of a malpositioning and hand or knee kind of a gait, what results is the other joints actually get affected. There may be increased chances of arthritis in these joints. Therefore, to decrease the stress on other joints, because one of the two joints are not actually working, usually limb length discrepancy has to be dealt. Limb length shortening can be actually dealt with Either shoeraise, if it's very small, 2 to 5 centimeter shortening. It could be dealt with leg lengthening, that is use of Elizarov to lengthen the bone, or using a bone transporter so that the leg length discrepancy can be decreased. Or that other option is epiphysiodesis of the contralateral side, that is the normal side, so that, as we know, that this side which is short cannot grow properly, we can block the growth of the other side, so that the limb length discrepancy does not goes beyond a certain limit. Disturbances of skeletal modeling may be present. Usually there are changes obvious with the growth. There may be torsional or angular deformities, maybe muscle and joint contractures, and depending upon, there's a complex deformities sometimes as well. And not only one surgery, maybe multiple surgeries required. Initially there may be release of certain areas, there may be a tightening of the other side may be required, then associated with osteotomies, they may be associated with bone transport and shortening, so that multiple level, maybe one, maybe two or three surgeries may be done to completely correct these deformities. There may be associated with vascular dysfunction, which have intact sensation but usually have cold blue paralyzed limb. Sympathectomy may be an option in case of if there is a chance that this eventually would result in gangrene of the patient. In this section, we have gone through the upper motor neuron lesions such as spinal dystrophy and poliomyelitis. Nowadays, all the acute presentation has very rare of the poliomyelitis, and it's almost been eradicated in the world except with a few countries. But yes, acute presentation is still can present with acute fever and headache. But the main burden of the poliomyelitis is actually the deformities and the contractures and the problems that it presents. And it's actually kind of a challenge sometimes to deal with these kind of pathologies when in adulthood, especially with the patients affected with poliomyelitis. Thank you very much. Keep watching sqadia.com.